noisy here, and I hope you enjoy this morning's presentation.
Thank you, Sarah. Yes, it's my great pleasure to introduce my colleague Mona Jeffries to you today. Mona's a Research Fellow in Epidemiology here at the Health Services Research Centre at Victoria University of Wellington, New Zealand. She trained though at the London School of Hygiene and Tropical Medicine and at Bristol University, and her primary research interests centre around health equity and longitudinal data analysis. And we're really fortunate to have her working with us here at HSRC now on projects looking at access to primary healthcare services. So today she's going to be presenting work from analysis of 10 years of the New Zealand Health Survey, particularly focused on who's accessing low-cost primary healthcare. So Mona, I'll just hand over to you. Look forward to hearing what you have to say, and then we'll have questions at the end. Thanks very much.
Lovely, thank you very much, Janet, and kia ora tātou. Welcome everybody, and thank you for joining in this webinar. So yeah, I'm going to be talking about equity in access to primary healthcare in Aotearoa, New Zealand. So this is a piece of work that's come about as a result of a collaboration. I'd like to acknowledge my co-authors on the paper that we recently had published in Health Policy, Maiti, Lynn, Kirsten, Liz, Michael and Jackie. But as you can imagine, this is a wider piece of work, and there have also been other people involved. And in particular, I'd like to acknowledge Karen McBride Henry, who is currently the PI on the programme grant from the Health Research Council of New Zealand, who are funding this work. So although some of the data I'm going to present are what's recently been published in Health Policy, I'm also going to be bringing in other pieces of work that we've done, and there's also been updates to the data available to us. So what I'm presenting here isn't identical to what was published, because we have 2 more waves of the health survey available. So before I begin with exactly what we've been working on, I just wanted to give an overview of the funding of primary healthcare in Aotearoa, New Zealand. So many of you may or may not know, particularly those of you who are listening in from Australia, that GPs in New Zealand essentially work in a private capacity, running their businesses on a small business for-profit model. The funding for those businesses have essentially 2 streams. There is capitation funding from the Ministry of Health, which flows through district health boards and primary health organisations to the GPs. And those are, so capitation funding is a per person, per capita funding, which varies by, the amounts people get vary by age and sex, and also by the type of practice, which I'll come on to explain in a moment. That capitation funding is supplemented by a user co-payment. So when you go to see a GP, then you are asked to pay. And the amount that you pay, again, depends on the type of practice, but varies between about $20 and $60 for an adult. So that describes most of the primary healthcare model that's used in New Zealand, but there are also what we might call third sector clinics. So these are non-government funded, non-profit, so not-for-profit businesses or organisations. Some are staffed by volunteer clinicians, but those are fairly few and far between. And then there's also a very important stream of provision of care through Māori health providers. Now, most of the primary care provision that Māori health providers offer is not medical, so not GPs, but a lot of it is community or district nurses, health promotion, and that sort of thing. But what I'm going to be focusing on are the mainstream general practices. A lot of change has come about in the last 20 years as a result of the launch of the primary healthcare strategy in 2001. And the idea of this strategy was really, there were 3 main prongs to it. One was to focus the work of primary healthcare on disease prevention in addition to treatment. A really strong focus on overcoming inequities which are pervasive throughout the health system in New Zealand, and a focus on integration across services. And although it was named integration across services, the key area that's been worked on has been the integration of primary and secondary care, so GP practices and hospital-based care. The primary healthcare strategy came with funding, so there was a huge funding increase for primary healthcare, and that primarily was directed through primary health organisations. So there was the introduction of these PHOs, which are groups of general practices. The incentive for people to become part of a PHO is through enrolling with a general practice, and if you are enrolled, then you are entitled to lower fees. Enrollment rates now are high. Across most of the country, they're somewhere between 90 and 95% of the population being enrolled in a general practice. As part of the primary healthcare strategy, there have been numerous policies to try to improve access to care, as well as some of the other strands of action. And one of the key policies in the early years of the strategy was the VLCA scheme. So VLCA practices stands for very low cost access practices, which sometimes are just called access practices. These are practices who offer care to populations containing over 50%, so over half of their enrolled population need to be what is defined as a high needs patient. So that's based on ethnicity or area level deprivation. So if over half of the enrolled population are Māori, Pacific, or living in the most deprived quintile area, and I'll describe that in a moment, then practices can choose to be a VLCA practice. Now, throughout this talk, I'm going to be talking a fair bit about area level deprivation. So I'm sure many of you will know that we use the NZ-DEP measure in New Zealand. It's based on 9 census variables. And these are grouped together for small areas, and they classify areas, so they rank areas which are then broken down into quintiles. So when I say NZ-DEP 5, I'm talking about the lowest or the most deprived quintile, or 5th or 20% of the population living in these areas. So if a practice chooses to be a VLCA practice, they receive a higher level of capitation funding from the government. In return, then they have to offer a cap on the co-payments that they ask for. So they have to undertake to provide free care for under 14-year-olds, to not charge more than $13 for 14 to 17-year-olds, and not charge more than $19.50 for adults. Now, those are caps, and a number of practices do provide much cheaper care than that. But this is the agreement that they enter into in return for the high level of capitation funding. So about 30% of general practices at the moment are VLCA practices, and the other practices are at leave to charge whatever they want, but typically then they charge between $40 and $60 per visit to a GP for adults. There's a new policy that's recently come in, the 1st of December 2018, and that allows the VLCA cap, so those prices that are on the screen, to be applied to people who hold a community services card, which is essentially a means tested benefit. So if you are earning below a very low level, I have to say, of income, or if you're receiving a means tested benefit in terms of a housing benefit, then you're eligible to apply for a community services card. And this new policy that's recently brought in allows, if general practices sign up to the policy, then it allows people with a community services card to receive care for those lower level of payments. So as you can imagine, then there have been a huge number of policy initiatives since the launch of the primary healthcare strategy. These were summarised really nicely in a paper by Don Matheson. And I just wanted to highlight some of the actions which are of particular interest to us in terms of thinking about equity of access. So the New Zealand Health Strategy in the year 2000 talked about equitable access regardless of ability to pay, but as I'm going to show you throughout this talk, then that has not been achieved. The primary healthcare strategy brought in a number of different initiatives, and the idea was to reduce financial barriers to those with greatest need, which informed the VLCA practice introduction. In the 1990s, there was a high user health card, so there are subsidized GP consultations for people who have chronic conditions or visit a GP more frequently than once a month. The Care Plus initiative brought in the idea of some primary healthcare visits, some free visits for people who need additional care in managing chronic diseases. The VLCA scheme, as I've talked about, came in 2006. And in terms of care for children, then 0 fees were brought for under 6-year-olds were brought in 2006, and that's since been extended, and now the vast majority of practices, including all VLCA practices, offer free care for under 14-year-olds. And although this table was published prior to 2018, there was the Community Services Card policy, which I'll talk about again as we go through the talk. Now, mostly, I am going to be talking mostly about equity because that is the primary focus of this talk, and mostly talking about equity for Māori. Now, as many of you will know, Māori are protected through the Treaty of Waitangi, Te Tiriti o Waitangi, which was signed in 1840 between Māori representatives and the Crown. This is embedded in health legislation through the Health and Disability Act of 2000. And the interpretation of the articles of the treaty as they apply to current health policy have been really nicely articulated in the publication that's up on the screen at the moment. So this is a view on Māori health equity, which was published by the Health Quality and Safety Commission last year. And one of my colleagues, Liz Salison-Loshman, has written a really clear, easy to understand interpretation of the current understanding of the interpretation of the treaty as it currently applies to current New Zealand's health policy rather than historical. So there's a number of there's different articles of the treaty, and as how they inform current health policy, we need to think about kawanatanga, which is representation of Māori and participation at all levels of the health system. And so this is not just in terms of health provision, but also in terms of health policy. Tino rangatiratanga is about self-determination, and this has been interpreted in policy as the provision of mainly Māori health providers, but also the involvement in co-design processes of healthcare provision. Oriteitanga is about a guarantee of equity, and this is not just a guarantee of equity of health outcomes, but also a guarantee of action on inequity. And the importance of wairuatanga, the protection of custom, of tikanga, of te reo, of Māori language, are all very important in terms of acknowledging the importance of the treaty in healthcare provision and policy. Many of you who are working in Aotearoa New Zealand at the moment will know about the Y2575 claim under the Waitangi Tribunal. The first outcome of this was published last year, and the Waitangi Tribunal found that the Crown has breached the treaty in 2 main ways: failing to design and administer the current primary healthcare system to actively address persistent Māori health inequity, and failing to give effect to the treaty's guarantee of tino rangatiratanga. And so for those of you who aren't familiar with this document, I would strongly recommend reading it. It provides an extremely comprehensive and useful overview of inequity within the healthcare system, not just in terms of outcomes, which is clearly very well published, but also in terms of policy. It's impossible to talk about Māori health outcomes and access to services without understanding that Māori still face the persisting consequences of colonisation. So when we talk about the most deprived quintile, that's that NZ-DEP I was talking about, and clearly being a quintile, we'd expect 20% of the population to live in the most deprived areas, but actually 40% of Māori live in the most deprived areas. Māori face higher levels of unemployment and lower home ownership. And if you can imagine how that's going to then affect intergenerational poverty, then you can think about how having land taken away, which is then not able to be passed on to subsequent generations, allows for the embedding of social inequity. As well as lower home ownership, there's poor quality many Māori live in poorer quality housing, which has both direct and indirect effects on health, and likewise with lower education levels. So it's not just the health system which is failing Māori, the education system's doing a pretty good job in that area as well. So not only do Māori then bear the burden of the poor health consequences as the result of these social determinants of health, but they also bear these in the face of a Eurocentric health system which is failing Māori. So having given a very long introduction, I'd like to come on to some of the work that we've done and share some results with you. So the aim of what I'm going to present to you is to describe cost barriers to care. I want to talk about care, meaning care, primary health care. Got to look at some of the trends in reported fees to access primary health care. And here I'm only focusing on seeing GPs, not talking about other aspects of primary health care at this stage. I'm going to share some of the socio-demographic determinants of access to low-cost primary health care that we've looked at, and talk about some of the potential explanations of low-cost primary health care for Māori. So all the work I'm going to present to you comes from the New Zealand Health Survey. So this was started in 1996-97. It was conducted 5 years later, again in 2002-03, again 5 years after that in 2006-07, again 5 years later, 2011-12, and since 2011-12 it's been constantly in the field, and annual updates are reported. And like I said to you, we've just very recently got the data for the 2018-19 wave, so this is about as current as the data comes. Unfortunately, the 2019-20 New Zealand Health Survey was affected by COVID, so those results haven't yet been released because they didn't get enough respondents because they had to stop in March 2020. So every year, about 12,500 adults are surveyed in the first year of what I've included here. That's probably only about half that. So in total, we have over 139,000 adults in the analysis I'm going to present to you, including over 30,000 Māori. Each of these people take part in a face-to-face interview with trained interviewers. And there are two questions that most of my analyses are based on. So the first is, in the past 12 months, was there a time when you had a medical problem but did not visit a GP because of cost? So I'm going to call that a cost barrier to care. And then people were also asked exactly what they did pay the last time they went to see a GP, thinking about your last visit to a GP, what were you charged for that visit? There have been some changes over time, how these questions were asked, and particularly for that second question, the categories that people were allowed to complete. So some of the data I'm going to really focus on the later years, so the questions haven't changed since the 2011-12 survey. When you get these data, so you apply for them from Stats New Zealand, they come with integral survey weights. And so I've used these, and I used a weighted survey analysis so that the results are reflective of the population of New Zealand in terms of age, ethnicity, and urban-rural status. So looking first of all at that cost barrier to care, so people who say that they couldn't afford to see a GP when they needed to at least once in the last 12 months. This hasn't changed. Over looking at the last 8 years worth of data, then between 13 and 14% of the population report that cost barrier to care. When we look at it by ethnicity, then we can see huge differences. So the average for the non-Māori population, that's the red line on the bottom, is about 13%, and for the Māori population is about 22%. And clearly, given the smaller proportion of Māori, or numbers of Māori in the study, the confidence intervals are a bit wider, but you can see that there's a very, very significant difference between Māori and non-Māori. When we look by deprivation, then we can see, looking first of all at the red columns of non-Māori, as you move across the deprivation quintiles, then people are more likely to report a cost barrier to care, which is probably what we would expect. But at every deprivation quintile, Māori are considerably more likely to report that. So it's not just in people who live in the most deprived areas, it's even people who live in the most affluent areas. Māori are still nearly twice as likely to report a cost barrier to care. And looking at that most deprived quintile, then it's important to remember that this is where most of the VLCA practices are based, or I should say that most of the people who live in the most deprived quintile have access to VLCA practices, so have access to low-cost primary health care. It's also important to remember that 40% of the Māori population are in this blue bar on the right-hand side of the screen. So 40% of the total Māori population, a quarter of those are experiencing a cost barrier to primary health care. I then wanted to look at it by income because there's a lot of problems with using an area-based measure and applying it to individuals in terms of deprivation. So I split people according to household income into low income and what I've called higher. So the definition of low income that Stats New Zealand use is taking the median income, which means half the households earn below the median income, taking that dollar value and then taking 60% of it. So it's really the very lowest income households here we're talking about. And in terms of absolute dollar value, we're talking about below a household income of below about 50,000 New Zealand dollars. And when we look at people who are really earning very small amounts or on benefits, about 1/3 of Māori, that's the higher blue bar, report a cost barrier to care, compared to about 18% of non-Māori. So I think just to summarise that then, it's really clear that Māori are bearing the brunt of having to pay for primary health care. So then we start looking at what people actually report that they pay. So here I've taken that reported value of what people say they paid the GP last time they went, and I've converted all those into the equivalent of the 2020 value of the New Zealand dollar, because clearly over time the value of the dollar has changed. So we can see that the primary healthcare strategy, which was launched in 2001, so just before the second point on that graph, had an impact on reducing the mean co-payment that people paid. And that was even more obvious in the going from the 2006 to the 2011 wave of the New Zealand Health Survey, when those VLCA practices were really becoming more common. Now, it's good to see that Māori are paying less. So Māori are represented here in the blue line below, and over time there has been very little change, that on average the Māori pay about $10 less than non-Māori to see a GP, which is great, but bearing in mind those cost barriers that I've just been showing you, then we still clearly have got a problem. When we look by ethnicity, then we can, so not just Māori, non-Māori, but here I've used prioritised ethnicity, and we can see that Pacific people in the red line at the bottom have consistently had to pay less to see a GP. Although I should say, I haven't shown you the cost barrier to care for Pacific people, but it's as high as Māori. The blue line then is Māori, and Asian people tend to pay about $5 more than Māori, and what I've termed other, but is primarily New Zealand European ethnic group, pay again about $5 more. Now you can see here there's in the very last wave of the New Zealand survey, so the one that's labelled the 2018, but it's actually 2018-19 data, then there has been a slight reduction for each of the top three groups, so the New Zealand European group, the Asian group and Māori, a reduction in terms of the average co-payment, which is not evident for Pacific people. And you'll probably say, well, those are probably just little fluctuations and may not be significant, but actually when we come on to look at low cost care, we'll see how important those data are. When we look by deprivation, so again, going back to our NZ-DEP measure, where we've got 5 different quintiles, then people in the lowest deprivation areas consistently pay the least to access care, which is exactly what was intended and what we would expect from the VLCA policy. And you can see as you go through the deprivation levels, with rising levels of affluence, then there are rising levels of reported fees paid to see a GP. When we look by age, it's quite interesting that the younger people, so that's the blue line, the 15 to 24-year-olds, tend to pay the least. That might be that some of those are still children at school. The question technically says, what did you pay last time you saw a GP? Could be their parents paying, could be that they're accessing school health services. So we don't quite know what's going on, but there hasn't been a lot of change. The impact of the primary healthcare strategy, so remember launched in 2001, but biggest impact sort of happening from 2006 onwards, has really had very little effect on what young people are paying to access services. Whereas the effect on working age people, so people in the red and green line, tend to have benefited more. So in summary then, the fees paid, the fees that people pay to access primary healthcare have reduced in real terms since the introduction of the primary healthcare strategy. On average, Māori pay about $10 less, but bearing in mind that cost barrier to care, then there is still a huge issue of non-affordability. There is a suggestion of fees reducing in the latest wave of the New Zealand Health Survey, but not for Pacific people. And it seems like most of the reductions since the introduction of the strategy, the primary healthcare strategy, has been for working age adults, not for younger adults or for older adults. So the next thing I wanted to look at, really to try to understand what the effect of the VLCA policy is to look at low-cost primary healthcare. So here I've defined low-cost primary healthcare as anyone who was paying less than the equivalent of $20 in 2020 New Zealand dollars. So everything being converted into 2020 New Zealand dollars, and anyone who paid less than $20 but did pay something, I've counted as low-cost primary healthcare. So here, people who accessed free primary healthcare are not included in these analyses. And just to reiterate that although I talk about the VLCA policy, then the community services card policy is actually quite important here, so has been going for less than 2 years. And just to give you a bit more detail on how it works. So if you are registered with a VLCA practice, and you are a community services card holder, the practice receives extra funding for you in the assumption that you have got higher health needs. But as an individual, you still pay the VLCA rate. So actually there's, in terms of accessing healthcare for an individual, there's not an awful lot of incentive to register for a community services card, although it does have other benefits as well. For accessing a GP, then it doesn't have a huge impact because you still have to pay the rate you would be paying if you're registered at a VLCA practice. Now, non-VLCA practices can opt into the community services card scheme if they want to. So if they do opt in, they receive extra funding for those people who've got community services cards. And then that co-payment cap applies to the community services card holder and their immediate family. So looking at what happened to low-cost primary healthcare, you can see that there was a huge increase from 2006 to 2011 of people who were accessing low-cost care. And that, I think, is a very clear result of the VLCA practices coming into force. And now when we were looking at average fee paid in the previous sets of graphs, then I made quite a lot of big deal about the last wave of the New Zealand Health Survey, and this is why. Because you can see here that it was muted when we just looked at average fees, but when we look at the proportion of people accessing low-cost care, there's been a huge increase just in that last wave, which to me can only be explained by something good happening with the community services card policy. So just in terms of the exact dates shown down here, The New Zealand Health Survey runs from the 1st of July through to the end of June. So the data here that are described as 2018 are actually from July 2018 to June 2019. So they start about 9 months after that policy came into practice or into effect in December 2018. When we look at split those data by Māori and non-Māori, we can have for once, a good news story for Māori. Then Māori seem to be benefiting in the same way as non-Māori in terms of that community services card policy. So we can see that increase quite clear for both groups. However, when we look in a bit more detail by other ethnic groups, we can see that although there's benefits for Māori, for Asian people, and for New Zealand European people, there's a very clear reduction for Pacific people. Now, as you can see from the confidence intervals, the numbers of Pacific people in these analyses are small with the wide confidence intervals, but it seems to me quite a worry, and I think this is something that we need to keep a very close eye on to know what is happening for Pacific people. They have got the highest level of access to low-cost primary healthcare, but if those inequities are going to be increasing, so if the proportion of people accessing low-cost care is really coming down, then that is a significant worry. When we look by deprivation, we can't really see any distinct patterns that are that obvious. There seems to be kind of a rise in the NZEP4 group in the last year, which is interesting because if you can imagine living in a fairly deprived area, but not the most deprived areas, you may not have access to a VLCA practice necessarily because of where you live. And so it may be that the community services card is benefiting that group most. Having said that, then a similar rate of increase is seen for the green line for NZEP2. So I'm not quite sure what's going on here, but everyone's moving in the right direction. So something good appears to be happening. When we look by age, sorry, it's a bit tricky to see with the confidence intervals here, but if you just focus on the colored lines, the green, the red, and the purple in the last wave of the New Zealand Health Survey, then each of those are reporting, so those are people who are aged 25 and above are reporting higher access, so a higher proportion of those people are accessing low-cost primary healthcare. Whereas we don't see that for young people. There seems to be a small reduction. So again, just like with the Pacific people, I think we need to keep a really close eye on what's going on, really hoping that we're going to get some data from the New Zealand Health Survey for the latest wave, despite the COVID disruptions, to see if those patterns are continuing or if it's just a blip. So in summary, then, access to low-cost primary healthcare has increased since the introduction of the primary healthcare strategy. Māori have benefited more than non-Māori in terms of higher levels of access to low-cost primary healthcare, but these are not adjusted for need. So we know that Māori bear the brunt of most high levels of most chronic and infectious diseases. So we have to bear that in mind. And as I've shown you the results on affordability, then we know that Māori face much higher levels of cost barriers to care. Looking at the most recent data, all ethnic groups had improved access to low-cost care other than Pacific people. And as I've reiterated, then we do need to keep an eye on what's happening there. And likewise with young adults. So with those 15 to 24-year-olds, then they don't appear to have benefited from the recent increase in access across other age groups. So we then had a look at sociodemographic predictors of access to low-cost care. So it's a slightly tricky graph here, but just to show you the different groups of bars, we looked at age, we looked at sex, we looked at deprivation, at income and education levels. And I looked at these separately for Māori and non-Māori. I'm just going to move on to the interpretation because it's quite tricky, but just to say that what's happening here is that the Māori are looked at in comparison to Māori. So the baseline is the left-hand bar in each of the small groups of sociodemographic measures. and likewise for non-Māori. So it's not a Māori non-Māori comparison. It's a comparison within ethnic group. And just picking out the interesting results, so Māori women appear more likely to access low-cost care than men. And that's really important because actually Māori women, although I didn't show you the split by gender in terms of the cost barrier to care, Māori women report a much higher cost barrier to care than men do. So although there's a higher level of need, then there's also a higher level of access, apparently. And looking at the comparison of Māori and non-Māori for deprivation level, then it seems that accessing low-cost care in deprived areas is actually easier for non-Māori than it is for Māori. So we need to understand, I think, a bit more of what's going on here. Now, these results are all mutually adjusted for each other, and if you're interested in the unadjusted results, those are also presented in the health policy paper that I mentioned at the beginning. The next thing I went on to do was to do a comparison of Māori compared to non-Māori. So on the left-hand bar here, then we can see that Māori are about 2.5 times as likely to access low-cost primary health care compared to non-Māori. And then I was trying to understand what contributes to that. So have added other variables to the model. So adjusting for age and year, and so year of survey and sex made no difference to that. And adjusting for deprivation, you can see that in the third bar, there's quite a marked reduction. But even having adjusted for deprivation and carrying on also adjusting for income and education, Māori still remain at about a 70% higher chance of accessing low-cost primary health care. The interpretation of that is really tricky because without an understanding of need, then it's really hard to know whether that's a good thing or not, whether there should be a greater difference between Māori and non-Māori, or whether it's appropriate. Looking then at each level of deprivation, because we know that that policy is mainly aimed at deprivation level 5, as well as areas of where high proportions of Māori and Pacific people live. Access to low-cost healthcare was similar, comparing Māori to non-Māori in each level of deprivation. And that was a bit of a surprise to me because I would have expected it to be much higher in those DEP 5 areas. So although I know I've rushed through those last few slides, partly because they're really tricky, partly because we haven't got a lot of time and it'd be nice to have some questions, then I think all these are sort of adding up together to be sort of separate pieces in the puzzle to answer the question of whether there is inequity in access to primary health care. So we know that Māori are more likely to access low-cost care, but how is that related to need? That's something that we don't know. We know that Māori face higher cost barriers to care. Probably would have expected Māori to have benefited more in NZDEP areas, NZDEP 5 areas. So in the more deprived areas, might we have expected Māori to have had a higher level of access to low-cost care compared to non-Māori, whereas actually across all the deprivation levels, it was similar. And then something I haven't really touched on at all, but is about the proportion of, or so the average number of times people go to the doctor. Māori have got a considerably lower rate of consultations compared to New Zealand Europeans. So an average of 2.7 visits per year compared to 3.2 visits for New Zealand European people. And given what we know about levels of illness, burden of disease among Māori, then that's not necessarily what we would expect. So I think each of these is pointing towards a yes, there is inequity in access, and particularly in financial access to primary healthcare for Māori. Just to touch on the fact that all I've spoken about really is paying to see a GP. Obviously, there is a much wider primary healthcare team, and certainly there's good evidence that Māori are more likely to see practice nurses and have a higher proportions of consultations, which may be appropriate. It may be that if you have got a higher burden of chronic disease, then having regular monitoring with a practice nurse is as, if not more, appropriate than regular GP visits. In New Zealand, we also have prescription co-payments, which is another financial barrier. So people have to pay $5 per prescription item, up to a maximum of $100 per year. And I have got some data to show you on that if we've got time. I think we need to think about the wider effect on the whānau, so on the wider family. If somebody is not going to see a GP when they need to, then people, so particularly if it's a caregiver, then people may be, mothers in particular, may be more likely to have to take time off work, might have an impact on income, might be less able to look after their family. I haven't got data to present here to you on patient satisfaction, but I think it's quite important to think about. And actually a lot of the data that comes out of the Health Quality and Safety Commission patient satisfaction or patient experience survey in primary healthcare shows that Māori experience relatively high levels of satisfaction similar to non-Māori. However, there is very good evidence to show that the quality of care that Māori receive is lower. And going back to that publication from the HQSC that I had on one of the earliest slides, there's very good evidence there throughout the whole healthcare system, not just primary healthcare, that quality is lower. The quality of care received is lower for Māori. I'm just going to show you 2 slides on prescription co-payments because it's something I'm particularly interested in at the moment. 7% of people, and it's not really changing except possibly in the last year, saying that they haven't filled a prescription or at least one prescription item due to cost. Massive differences by ethnicity, so about 5% for the non-Māori population, about 12% for the Māori population, although it does look like things are improving over the last few years, which is really encouraging to see. Again, when we split it by other ethnicities, then Pacific people have, again, having a huge burden of being unable to fill prescriptions, whereas Asian and New Zealand European people having a markedly lower reporting of that. Again, when we look by deprivation, then deprivation doesn't really say at all because the proportion of Māori who can't fill a prescription living in the most deprived areas is about 17%, whereas for non-Māori it's about 10%. So I think in summary, we can say that cost barriers to primary healthcare and accessing prescriptions have not really changed, although possibly things are improving slightly. Consistently higher for Māori. At each level of deprivation, Māori are more likely to report being unable to see a GP or to fill a prescription. And from some of the earlier data that I showed you, the impact of being on a low income hits Māori harder. So what are the implications for all this work? It seems to me there's quite a lot. There's still an awful lot to do, a lot more for us to understand. In terms of health policy, then policies really have to work towards making primary healthcare more affordable. It seems like that community services card policy is working. However, there's lots of problems with accessing a community services card if you are eligible. And the level at which you become eligible is extremely, you have to have an extremely low income. Essentially, it's really only people on benefits. So I think there's a lot more work to be done there. In terms of health equity, not particularly based on what I'm showing you here, but also based on lots of other evidence, particularly from the Y2575 Waitangi Tribunal claim, as well as the recent Health and Disability System review, the Heather Simpson's report. It's quite clear that system-wide changes are required, that what we are doing is not working, and the efforts to redress inequity are absolutely vital to be continued and worked upon. Just to give you extra data from the New Zealand Health Survey, so this is something that the Ministry have put out, that 41% of Māori in the last year have faced a barrier to primary healthcare, not just cost, could be transport, could be getting an appointment. But those are people who we know have got a very high burden of disease and yet are not able to access the care that they need. So something has got to change. In terms of the wider whānau, so the wider family, then although care for children is meant to be free, there were 6,000 Māori and 7,000 Pacific children in the last year who weren't taken to the GP because of cost. Now, it's quite unclear from the way the question is asked in the New Zealand Health Survey what that exactly means. It could be that some practices are charging, but that's not very likely. It could be that adults owe money to the practice and so are not taking their children because they don't want to go to a practice where they owe money. It could be that taking time off work is an opportunity cost that people can't face. There's one primary health organisation that runs a lot of GP practices in South Auckland, where a lot of Pacific people live, that have a new model of care, which is that you turn up on the day and you wait for your appointment. You're guaranteed an appointment, but you sit and wait. Now, if you're paid by the hour, the opportunity cost becomes huge. In terms of research, that I think there's also some stuff that's coming out of this that's important. I think deprivation, although it's used a lot, is insufficient in trying to understand what's going on. It certainly doesn't capture all the measures of inequity that we're interested in. Income is household income, equivalized household income is an improvement on that, but there's also some research coming out suggesting that measures of wealth might actually be more important. So measures of home ownership, that sort of thing may be more useful in trying to disentangle exactly what is going on. And then I think it's really important that we know what the impact of not seeing a GP is. So people report these cost barriers to care, but the New Zealand Health Survey is simply a set of cross-sectional surveys. It's not a longitudinal study. So just to share some very recent data that we've got from the Growing Up in New Zealand study, where we've been looking exactly at this. So we're looking at children who are facing a barrier to seeing a GP. So not necessarily a cost barrier, but any reported barriers. So parents saying that they hadn't taken their children to see a GP in the last year. This is at age 2. The children who didn't see a GP were twice as likely to end up in hospital in the next 2.5 years as those who didn't report having faced that barrier. That was present for Māori and Pacific children, but not for New Zealand European children. And it was also present having adjusted for measures, a whole raft of socioeconomic measures, as well as health measures. So we can see in children, there's a very clear impact on what happens when you don't go to a GP if you need to. And I think knowing that for adults would be particularly useful. So we're hoping to do that. The New Zealand Health Survey is hopefully going to get into the IDI, which is New Zealand's administrative data framework. And once it is, we'll be able to link the New Zealand Health Survey to hospitalizations and other outcome data. So I'm going to leave it there. Just to reiterate, as Sarah said, there is a conference next year and very much hoping that that will be face-to-face and look forward to meeting many of you there. But in the meantime, really happy to take questions. Thank you.
Thank you so much, Mona. That was really interesting and yeah, somewhat sobering, much of your presentation. And I've certainly got some things to ask, but I'll perhaps begin with the questions that are in the Q&A. And again, if anyone else has got one they'd like to ask, please type it in. So several from Oliver Frank. First of all, he asks, you mentioned near the beginning about a substantial increase in funding for general practice that came from the primary healthcare strategy in 2001 and for several years afterwards. Just wondering if you can give us an indication of the amount or proportion of that increase. Do you happen to know?
No, sorry, I'm afraid I have no idea off the top of my head.
Yeah.
No, I could easily find out and let you know. A number of my colleagues are much more into the financial figures than I am. But no, I don't have off the top of my head how much was, I was about to say diverted, but it wasn't diverted. It was additional money. So it wasn't taken from the secondary care system. It was new money that was put in to back up the strategy. But no, I'm sorry, I haven't got an overall figure for that.
That's okay. And then you also mentioned that the New Zealand Health Survey asks Māori, or asks all the participants, how much they paid for their most recent visit to the GP. The person asks, is there no official record kept by government of how much co-payment each patient paid for that GP visit that you can access and search?
Yep, no, that is a good question. The data are there. We do get those data. We need to put in Official Information Act requests to get those. And we've got the most recent set of data just last week. So my colleague Mighty is working on those. The problem is that they're provided to us on an aggregate level. So we are told on average, then this group of people in this general practice page that, but we don't have it on an individual level that will allow us to then look at, for example, the impact of whether somebody has a community services card or not. They do tell us whether it's a VLCA practice or not, so we know that level of detail, but getting those aggregated data is nowhere near as good as getting individual level data that are also linked to health measures and health outcome measures. So my ideal would be if primary healthcare databases finally ended up in the IDI, because to me that would be the ultimate way that we could track individual level data. But at the moment, because of the way primary healthcare is essentially fragmented because of the private business model that it runs under, then there is no one that collates all those primary healthcare data in New Zealand. I know the people who run the medtech, so one of the PMS systems, do collect those data, and there are people beginning to use it, but it's hard to get and privately owned. So yeah, not ideal.
Next was just a comment, someone asking if they could have the slides afterwards. So just to let everyone know, yes, as Sarah said, the presentation and the slides will go up on the website in the next day or so. Then a question that says that here in Australia, 87% of services provided by GPs involve no co-payment by the patient. So does a zero co-payment happen in New Zealand at all, or does every patient, even in the VLCA practice, pay a co-payment?
So every practice can attract a payment. So every visit can attract a payment. In the non-VLCA practices, every visit does, and there's no maximum that you could pay per year. So you pay every single time you go. In the VLCA practices, then they are at leave to charge up to that threshold. Some of them don't, some charge nothing, but those are very, very few and far between. And some charge less than the threshold. So for example, the one in the area that I live charges $12.50 when they could charge $19.50 for an adult. And those extra costs are borne by the practice.
Maybe if I can just ask one following on about the VLC practices, Mona. You determine whether you're in a VLCA practice by the makeup of the area, the population in that area, rather than the individual patient being eligible for funding. And I know sometimes we talk about, would it be better for the money to follow the patient who actually has the need? Do you have any thoughts about that? And again, I suppose the other side of the coin is that some people who may not need additional funding but happen to live in a VLC area will have access to cheaper visits themselves.
It's a really tricky one, isn't it? I think there's probably pros and cons, because there are definitely people who've got higher needs who don't, because of where their practice is located, don't access the VLCA practice, and therefore are paying probably more than they would if they lived elsewhere. The problem with having it individually targeted is that it somehow relies on identifying those people, which is what the community services card does. But there's been a lot written about it fairly recently about how people, what proportion of people who are eligible for community services cards are not claiming it. And that may be because the process is quite difficult. You claim it through the WINS, so that where you get benefits from. It may be that if you are in unstable employment, you may be eligible for it for a bit, then you get a couple of months work, you stop being eligible for it, and then have to reapply again afterwards. So although that was one policy where the idea was for the money to follow the individual, then it's fairly imperfect. So yeah, I'm not quite sure what the answer is, but an interesting one.
Thank you. And perhaps we've just got time to slip in one last one. Someone is interested to know what drives your specific interest in equity or in equity research?
Goodness me. Well, I would say that it started probably about 18 years ago. I came to New Zealand and did the first analysis on survival from cancer. So not about how likely you are to get cancer, but once you've got it, how likely you are to survive. And I can still look at those numbers and almost start crying because it's just appalling. And I think that has driven me for the last 20 years to try to think about what we could actually do to make a difference, because ultimately everybody deserves access to care. Those people with higher needs deserve higher access to care. And yeah, I guess that keeps me going.
Yeah, thanks, Mona. And yeah, we all, I'm sure, wish you well with this important work. And thank you for sharing it today. And glad it's been published recently as well, or some of this work.
Thank you.
Yeah, so perhaps I'll just draw things to a close there, everybody. But thank you again for attending, and do have a look back at the presentation and slides if you'd like to look over anything again. So thanks for your attendance today, and enjoy the rest of your day. Kia ora.
Kia ora, thank you.